Hypertensive emergency and refractory hypokalemia, a unifying diagnosis. Cushing syndrome is characterized by excess cortisol, leading to widespread effects throughout the body. These include obesity, osteoporosis, muscle wasting, skin changes, and hypertension. Common causes include pituitary tumors, adrenal tumors, and exogenous steroids, but there are other causes as well. The case starts with a 62-year-old man with a 45-pack-year smoking history who came to the emergency department for shortness of breath. He was found to have hypertensive emergency, with initial vitals significant for a blood pressure of 218/109, an initial lab significant for a potassium of 2.2, and a troponin of 0.1. The patient continued to have difficult to control hypertension as well as refractory hypokalemia throughout his admission. He received a CT scan, seen on the bottom left-hand side of the slide, revealing a 7 cm by 9 cm right hilar mass, which, given the smoking history, was suspicious for malignancy. A secondary hypertension workup was initiated, starting with an aldosterone level which was elevated and an aldosterone to renin ratio which was less than 2.3, indicating a secondary hyperaldosteronism. Further workup of the mass included a PET scan showing extensive right hilar and mediastinal malignant appearing lymphadenopathy, as well as 2 cervical lymph nodes suspicious for metastasis. A brain MRI showed numerous rim-enhancing lesions suggesting metastatic disease. The labs ruled out an aldosterone-producing adenoma, and with the imaging findings, there was increased concern for Cushing syndrome. An 11 p.m. adrenocorticotropic hormone level and cortisone level were drawn, and a 24-hour urine cortisol and creatinine collection were initiated. The 24-hour urine cortisol was elevated, as well as the ACTH and cortisol levels, confirming a Cushing syndrome. Meanwhile, the patient underwent a biopsy, and pathology confirmed a metastatic small cell carcinoma of the lung. With a previous brain MRI showing no abnormality of the pituitary gland, the patient was diagnosed with an ectopic Cushing syndrome due to lung cancer. As seen on the clinical timeline, after confirmation of the metastatic small cell cancer, chemotherapy was initiated. Chemotherapy was continued as well as radiation treatment outside the hospital, and eventually the patient's hypertension and hypokalemia improved. As seen in the discussion, the patient was discharged on spironolactone 100 mg daily and lisinopril 10 mg daily with potassium 40 milliequivalents daily. With treatment, he was able to discontinue the spironolactone and decrease his potassium to 20 milliequivalents daily. A complete workup would have included a dexamethasone suppression test. However, the patient had difficult to control diabetes as well as severe anxiety, so this was deferred. Of note, ectopic Cushing syndrome only causes 12% of all Cushing syndrome cases, and small cell lung cancer causes 8 to 20% of ectopic Cushing syndrome cases. Teaching points include that Cushing syndrome should be on the differential when a patient has refractory hypertension with electrolyte derangements. Also, although small cell lung cancer is a well-known cause, it is also a rare cause of ectopic Cushing syndrome, and other causes should be ruled out first.